Ani and bonjour. My name is Dr. Virginia McEwen, and I'm coming to you from Thunder Bay, Ontario, which is the traditional territory of the Fort William First Nation. I'd like to acknowledge my gratitude for being able to live and work in this beautiful region. And I'd also like to acknowledge the direct role that the North Caribou Lake First Nation has had in my pathway to medicine. I am a family physician with a focused practice in chronic pain. And before we get into my disclosures, we are going to focus today on Mast Cell Activation Syndrome, the pain and neurological manifestations. With respect to conflicts of interest, I have none to declare. In terms of medications that are mentioned in this presentation, in chronic pain, it's very common to use medications off-label, and certainly there is no exception in Mast Cell Activation Syndrome. None of the medications reported in this presentation have been studied specifically in the use of this syndrome. Finally, with respect to the expertise that I supposedly carry, I am a family physician by training, and certainly that has a degree of widespread appreciation for multiple issues in our patient population. I am not a specialist. I am not an expert in mast cell disorders. However, I would like to encourage the audience to consider that even as a family physician, certainly we have a huge role to play in recognizing and treating this syndrome. Secondly, I am new to practice, and as such, I want that to be hopefully an inspiration to patients and care providers to consider that even such a complex condition could be within your grasp to understand in a relatively short period of time with a little bit of effort. I want to humbly acknowledge that a lot of what we will talk about today may look very different 5 years from now. And certainly, as we learn more about this, encourage everyone to remember that we don't know as much as we think we do in medicine, and that we should maintain an open mind and a spirit of scientific inquiry. This quote by Timothy Leary, I think, is a little fun, a way of me poking fun at my specialist colleagues. If you listen to neurologists and psychiatrists, you never fall in love. Well, I'd like to say with respect to Mast Cell Activation Syndrome, or MCAS, as I'm going to be referring to it in the presentation, is that if we listen to neurologists when they get presented with a lot of these symptoms, you may end up with a diagnosis of functional neurological disorder, or with psychiatrists, somatic symptom disorder. So hopefully, if you are one of these specialties, that you may expand your differentials moving forward. Our learning objectives today are to have a current understanding of the perspectives on Mast Cell Activation Syndrome. We're going to look at the basics of diagnosis and treatment. We will be looking specifically at neurological manifestations, as that is the theme of this year's conference. And I'd like to take some time to briefly advocate for what our needs would be for supporting this patient population. So we love analogies. And in medicine, one of the most common analogies is, if you hear hoofbeats, don't think about zebras, think horses. And certainly, as any patient with Ehlers-Danlos Syndrome may appreciate, this does not apply in that sense. And as such, the Ehlers-Danlos patient population has adopted the zebra to more adequately represent who they are in the medical world. Now, I would argue that depending on the part of the world that you live in, zebras are actually fairly common, and I actually also believe that Ehlers-Danlos Syndrome is much more common than we appreciate. So who knows, maybe that animal will change in future once we're actually not underdiagnosing it. Now, of course, anyone with Ehlers-Danlos syndrome also has the possible comorbid diagnosis of POTS. So this animal is to salute our POTSy friends with postural orthostatic tachycardia syndrome. And finally, Mast Cell Activation Syndrome perhaps is best represented by the elephant. Not only because I think that it is the elephant in the room in that it is a very common condition that we are just not catching. And secondly, if we consider the parable of the 6 blind men and the elephant, well, in this picture it's 5 actually, but at any rate, the story goes that every blind man thought the elephant was something different when they assessed just part of the elephant. So, and this is what we see in medicine as well, that there's siloing of our specialties. And when somebody goes to a gastroenterologist with gastrointestinal symptoms, they may come away with a diagnosis of irritable bowel syndrome. And when they go see a pain doctor, it might be fibromyalgia, or a neurologist, functional neurological disorder, and so on. So you get the sense that when we are always looking at just part of the overall picture, that we're not appreciating the animal in its whole. So what is MCAS? I think the best definition that I've come across is that it is a chronic, inappropriate, non-neoplastic mast cell activation that results in multi-system inflammatory symptoms that may include allergic phenomena and does not fit other defined allergic or inflammatory diseases. Maybe we need to back up even a little bit more though and say, what is a mast cell? Well, if you look at this picture, which maybe someone with some biology training might have seen, it's very pretty and it doesn't look like it should cause this much trouble, does it? But the truth is we actually don't know nearly as much as maybe we should about this cell. And that is reflected in that often when you look for the stem cell lines, it's often ignored. So if you look on the myeloid line on the left-hand side, there is a mast cell here, but when you look for pictures of this, you're going to come across 9 of these images before you find one that includes the mast cell. So very underappreciated compared to all of its other friends. Then in terms of what we actually learn about it in medical school, we learn very little. And I can say from my experience, the only thing I learned about it is in the far left column, in which they are implicated in type 1 IgE-mediated hypersensitivity reactions. And certainly this is a very important role that it has, but it also has many reactions that have nothing to do with the IgE pathway. And that's where we see a lot of the other symptoms that come along with it. The mediators that are most commonly released by this cell include histamine, which most people will be familiar with, as that is what gives us the pain and itch symptoms that we experience during allergic reactions. But there are several other very commonly released mediators that have many inflammatory symptoms. And as we learn more about this cell in recent years, it's been discovered that there are actually over 1,000 various chemicals that are released by this cell. So anyone who wants to geek out on what those other chemicals could be, there is an extensive cytokine encyclopedia that is listed at the bottom of this slide, where you could spend days looking at these various chemicals. So mast cells live in tissue, not the bloodstream, and we can't do blood tests to measure their counts. They have a common progenitor in the myeloid line, and then once produced in the bone marrow, they distribute to various parts of the body where they live in different tissues. And in those different tissues, they also differ from mast cells that live in other parts of the body. They live in highest frequency in parts of our body that connect with the outside world. So that's the skin, the gastrointestinal system, and the lungs. Many of the mediators released by mast cells have their effects within seconds, while others release over the course of hours. So that can make it very difficult to understand what the triggers are for an individual patient at times. And what makes it even more complicated is that they don't release all of these chemicals all at once. They can release mediators selectively, and as such have an impact on every system. So as a simplified graphic, this is a nice thing for patients to sort of have a snapshot of what they do and what their role is, and to kind of have a basic understanding. But then for healthcare professionals, we can maybe get a little bit more in depth, and it certainly gets even more complicated from here. Hooray. So if we look at the mast cell in the middle, it can be stimulated by a number of different triggers. So it could be allergens, of course, drugs or toxins, various cytokines or peptides that are released by other cells of the body, and then certainly also infectious sources. Then when they release their mediators, they have various impacts on different parts of our body. And I've listed different groups of mediators that have been associated with individual systems. We're going to spend more time later on talking about the neurological ones. So characteristics of MCAS are that overall the mast cell load is normal. Now this is different than systemic mastocytosis, and often MCAS and systemic mastocytosis are confused for each other, and they're very different. So systemic mastocytosis does behave more like a neoplasm in that the numbers of mast cells are abnormal, and the symptoms between the two are very similar. So that does make it a bit confusing, but it's important because MCAS is not a life-threatening condition, whereas systemic mastocytosis does have some implications in that respect. So it's important for patients to know that MCAS has a normal life expectancy, but there is a significantly lower quality of life and overall dysfunction. Symptoms occur in virtually any tissue or organ, which we mentioned, and they can wax and wane over many years. The symptoms can occur in an erratic, staggered manner, and it often starts in childhood, but as symptoms accrue, it's not recognized as such until many years later. Then there's also a group of patients that notice it starts specifically after an infection, where things were pretty good in their life up until that point, but after X infection or X trauma, that's when all of their symptoms started. In terms of prevalence, allergies occur in up to 50% of the population, depending on which papers you look at. With systemic mastocytosis, this is a very rare condition. So before people worry about that, it only occurs in about 2.7 per million people. However, MCAS is thought to be quite prevalent, with one paper reporting a rate as high as 17%. Now, I have to say I'm rather skeptical about that high rate myself, but even if we at some point get to potentially a very accurate number in MCAS, if that's 5% or even 1%, that would have a monumental impact on how we understand medicine in general. And when we think about our medical training, when we think that schizophrenia, for example, occurs in only 0.3% of the population, and the amount of time that we spend learning about that condition, I think it would significantly change how we are taught in medical school. In terms of when symptoms start, the median age is 9. And then time to diagnosis at this point in time is 30 years, predominantly because this is a new clinical entity in the literature in the last 10 years. So it's very early on in our recognition, and hopefully that will change. The average number of comorbidities is 11, usually inflammatory in nature, and the average number of symptoms is 20, which is quite staggering when you think that any one of those symptoms could have quite a significant impact for a person. So we're going to shift now into diagnosis and treatment. So there are several diagnostic criteria that have been proposed. The first group is under Dr. Valent, and their criteria suggested that there needs to be mast cell related symptoms, and the symptoms they do tend to focus on are very consistent with anaphylactic reactions. And that's because this group is predominantly consisting of allergists and immunologists. They want to see 2 or more organ systems involved. And once somebody shows that there may be some clinical signs, they look objectively for a significant elevation of tryptase by 20% plus 2 nanograms per milliliter. And so you need to have a baseline test and one within 4 hours after a flare to demonstrate this elevation. So criticisms of this particular criteria is that it's the only marker they look at, although I do see signs in some recent publications that they are starting to consider other mediators as part of their criteria. And that's because logistically, it's extremely challenging to have patients obtain a tryptase within 4 hours of flare. Now, if somebody has anaphylaxis, they're probably in an emergency department and you may have traction to actually get this done. But if you don't have idiopathic anaphylaxis and you're just having a flare of your usual pain symptoms, then how is it that you're going to convince an emergency room physician to do this test and also achieve that within 4 hour window? As we know, the healthcare system is quite stressed nowadays. So the logistics of this have been criticized. And furthermore, in the absence of anaphylactic symptoms, this level is almost always normal. So it's not helpful for the broader MCAS group that may have many of these symptoms but don't test positive. Then finally, they also suggested response to symptoms by drugs that target mast cell mediators or mast cell stabilizers. And this is also problematic in the sense that in medicine, we don't really like to diagnose things based on a response to treatment. We want to have something that we can test and then we treat them. So it's a bit like putting the cart before the horse. However, that is basically what they've stuck with for over 10 years. Now, Dr. Moldering's group came up with a set of criteria that's a little bit more broad in terms of its consideration. It looks at multiple systems, and some of them overlap with the Valen criteria, but they've also published a questionnaire that looks at the symptoms of increased mast cell mediator release. And certainly they also look if there's a possible increase in the mast cells in the marrow. One of those is the major criteria. But then there are a lot more options in terms of the minor criteria. The ones that are most helpful are if a patient can get 2 lab markers, and they list several other options for those, or if they have positive CD117 staining, typically of gastrointestinal biopsies. There is also suggestion for genetic changes, but it should be emphasized there actually is no known genetic marker for mast cell activation syndrome as of yet. There is for systemic mastocytosis and other mast cell disorders. So that is not helpful in MCAS, but you may want to consider, ruling out the other syndromes that also merit management. Finally, they also have agreed to include symptomatic response to inhibitors. And the argument by both of these groups is that this does allow for patients who live in parts of the world where access to these tests is not feasible to have clinical consideration for this diagnosis, even in the absence of hard objective findings. And certainly, even though Canada is a developed country, we do not have access to all of these tests. We have tryptase and chromogranin A. And the heparin assay that is collected at most hospitals is not the high sensitivity assay that's needed to measure endogenous levels. It is a more crude measurement of patients that are being treated with heparin as a drug, which levels are typically much higher. Now, I encourage anybody who is interested in digging into the nitty-gritty of this that they read the paper referenced at the bottom of this slide, because the Consensus 2 group, the Moldering's group, actually does a phenomenal job of going through what the rationale is for each of the various criteria that are proposed, and that is explained in depth in their supplementary material. So with respect to that questionnaire I mentioned, the references that initially published this questionnaire are listed at the bottom of the second page. I have simply rearranged them because all of the clinical factors of an assessment are now on the left page, and the more objective findings are listed on the right page. I go through this whenever I have a clinical suspicion that a patient might have MCAS to kind of get a sense of what their pretest probability is of having a positive lab marker. If they have greater than 14 as their score, then that does support that there is mast cell activation. It doesn't mean they have the syndrome, but at least it gives us a sense that there's something going on there. And then I take the subsequent steps to evaluate them for MCAS. This is a schematic that I put together because I found it very confusing to kind of figure out how to perform these different tests. So, as I said before, the only tests that we have widely available in Canada are tryptase and chromogranin A. However, if you're in a larger academic center where the hospital has a much significantly higher budget, you might be able to convince your lab director to have these extra tests collected. And none of the tests are generally run in Canada. They tend to be shipped to the Mayo Clinic in the States. However, these tests are a little bit challenging because they have to be collected in chilled tubes, spun in chilled centrifuges, and kept in a cold chain for the entire probably 2,000+ kilometers that they need to go to get the testing done. So some centers in Canada may have a high sensitivity heparin that we can use. So in terms of proceeding through this, the first step is performing the questionnaire, and then if they meet at least that as a major criterion, then I will consider the lab testing or the CD117 staining if they've already had endoscopy completed and biopsies collected. If they have greater than 19 mast cells per high power field, that is one of the positive criterion for meeting diagnostic criteria, or 2 positive lab markers. The final option is symptomatic response, which is my least favorite. However, given the low risk of the options to treat the first steps, I think it's very reasonable to still include that. In terms of response to treatment, generally what I do with patients is I assign them the homework of working through this particular list of antihistamines, most of which are over the counter. And generally speaking, each antihistamine can be tried for up to 2 weeks. And within that time, there should be a notable difference if there's going to be any. Under my supervision, I tell them they can exceed the typical daily dose. So for example, for loratadine, that would be 10 milligrams daily as an over-the-counter dose, but under my supervision, I advise a patient they can increase to the maximum daily dosing as part of their trial. And I ask them to work through each one at a time and keep note of which ones they may have reactions to and which symptoms each helps them with. Once they have done that, it's typically around 3 to 4 months' time, and patients come back and report sort of what the experience was, and I can use that to support the diagnosis. Treatment principles overall, number one is to always avoid any triggers that the patient may have. So that could be quite broad. It could be certain drugs, it could be certain foods. Stress is always a very common unifying trigger for many MCAS patients, and so on and so forth. I briefly mentioned some of those before, and that takes time for many patients to sort out. Then step 2 is looking at all the different mediator antagonists, and patients often will respond with very low risk antihistamines or leukotriene antagonists and cyclooxygenase inhibitors. It should be noted that some patients with MCAS do have significant reactions to NSAIDs and aspirin, so that's something to bear in mind. Mast cell stabilizers are an option, and as a pain physician, this isn't part of the published recommendations for MCAS, but because one of the most common symptoms is pain and inflammation, I use low-dose naltrexone to support many MCAS patients with that. And I've never actually progressed to some of these more aggressive types of medications such as imatinib. Supplements are often also helpful, particularly vitamin C and quercetin have very good mast cell stabilizing properties. And MCAS often requires a combination of various treatments to really get control over symptoms until such time we are able to eliminate some of the triggers. So that's sort of an overview, but we're going to zero in a little more specifically on pain and neuropsychiatric manifestations of this condition. Common symptoms reported by many patients is pain and brain fog. Brain fog is loosely defined as concentration difficulties or issues with memory. Orthostatic intolerance, now often that overlaps with sort of more of a cardiovascular presentation, but there is a neurologic component to that. Cognitive dysfunction is common, and then certainly the more predominant mood symptoms tend to be anxiety and panic-like symptoms, PTSD symptoms. And then one of the preeminent researchers in mast cell disorders has found a significantly higher number of patients with mast cell disorders who have symptoms of ADHD or even autism. I don't have much more knowledge aside from that on that topic, but it is greater than the general population. Small fiber neuropathy is common. Fibromyalgia is a common diagnosis many patients arrive with, and then migraine headaches. So you can see as a pain physician why MCAS often crosses my mind as a possible differential. There was a study that looked at some of the most common symptoms in multiple systems, and the section of that chart that was specific to neurologic and psychiatric symptoms found a multitude of neurologic symptoms that are including headache, neuropathies, including paresthesias, and even motor deficits, tics and tremors, demyelinating polyneuropathies, and treatment refractory seizure disorders. Mood disturbances are often reported, as I mentioned, and also, of course, sleep disruptions and insomnia are common. I want to spend a little bit of time focusing specifically around pain. So there's a lot of interest in the pain community around various cytokines that are involved in the pain pathway so that we can try and target certain ones perhaps more effectively and maybe even someday come up with more pain medications, blah, blah, blah. But what's interesting is when you look at all of the different syndromes that we have that are very common in the pain world, and we look at the triggers that could be involved with mast cells, there's a lot of overlap. And a lot of the chemicals that we study specifically in certain disorders are also released by mast cells. So there's a high correlation with mast cells and the inflammatory soup that is commonly studied in the pain world. So CGRP is an example. Substance P is very commonly looked at. Multiple chemokines and various interleukins. So I think that is, the essence of the connection I want the audience to have. But then there's also a very nice schematic over here that sort of gives us a sense of the loop that we might have. So I mentioned that stress is a common trigger of mast cell activation. And when we look at a stressful event, it's a physiological response to have the release of cortisol-releasing hormone. And that happens to be one of the molecules that can activate mast cells. Then the mast cell goes on and to potentially release multiple other chemicals, which then trigger nerves to register pain, specifically C fibers, which is the most commonly studied pain neuron. And then that sends pain signals to the brain. However, what's also interesting is that it goes the other way too. So C fibers also release chemicals, so substance P and vasoactive intestinal peptide, and that can trigger the mast cell to release these chemicals as well. So it's not a simple unidirectional relationship. There is a whole host of relationships that we really don't understand very well, but it does at least give an understanding of how it sort of, from a bird's eye view, looks. With respect to pain, I want to spend a little bit of time specifically around fibromyalgia, because I'm almost positive that most patients with MCAS have been entertained with a diagnosis of fibromyalgia. So as a pain physician, I view fibromyalgia actually as probably a heterogeneous disorder where, because we don't understand what causes fibromyalgia, there's a whole bunch of people that are lumped together that may actually be slightly different groups of people once we hopefully someday have a better understanding of this group of patients. And I suspect one of the groups of patients are MCAS patients. And the reason for that is I'm going to have you look at the symptom severity score. And this is something that is used as part of the diagnostic criteria in fibromyalgia. Now, we are slowly getting away from that because a lot of experts on fibromyalgia feel it sort of takes away from the overarching criteria in which pain is the dominant symptom and the dysfunction that goes along with that in sleep and in daily life. But if you look at this symptom severity checklist, I've checked off all of the things that occur extremely commonly in MCAS. And you can see there is a substantial overlap. And even the boxes that I did not tick off still occur in MCAS patients. It's just not one of the most frequent symptoms. And that is derived from this chart that was published in that paper where they looked at those 400 patients who had objective findings on laboratory investigations that supported an MCAS diagnosis and looked at the prevalence of symptoms. And if you look at the frequency column here, fibromyalgia type pain, 75%. Other neurological symptoms, syncopal episodes, headache, paresthesias, cognitive dysfunction. These are all extremely common symptoms in MCAS. Certainly you can go through the list at your leisure later, but suffice to say, there is a significant degree of overlap. So that is something that I now consider as a possibility that we will need to entertain in the research in future. Now, specifically around neuroinflammation, there is a brief little table that I thought was helpful in understanding why mast cells can be problematic at a neurological level in the brain. So again, going back to the stress response with the release of cortisol-releasing hormone and neurotensin, that releases a bunch of chemicals, different cytokines that then go on to disrupt the BBB or the blood-brain barrier. And that then allows for the recruitment of circulating lymphocytes and stimulation of the glial cells, as well as their proliferation in the brain. And this is important because when we think about other conditions where certain barriers have been breached, so I think of the gastrointestinal system, where there's now some degree of understanding about leaky gut because of the inflammation that occurs at that level that then allows for things to cross the gut that should not. It's the same thing with the blood-brain barrier. There are certain things that should not cross, and they do. Now, when mast cells are activated in the brain, this does cause depletion of histamine. And histamine, at the end of the day, is actually a fairly important molecule. It's not all bad. It does have an important role, particularly in motivation. And it has chemical similarities to dopamine. So when we deplete histamine, we are getting some of those depressive symptoms and difficulties in cognitive processes that require motivation. So I thought that that was a very nice explanation of how that's involved cognitively. So that sort of gives a brief overview of pain and neurological manifestations. I want to take just a minute now to say, what is it that we need to support MCAS patients moving forward? So number one, we need care providers at multiple levels of healthcare that are willing to actually treat what is likely a common condition. So I don't think this is going to be something that should be only primary care, Rather, I think we need to, in multiple specialties, come together and say, okay, there is a role for multiple different groups of experts to come together on this. I think we need better access to reliable testing, because if we want to have patients have some legitimacy around this diagnosis, because let's be frank, often patients who are given the diagnosis of MCAS then struggle in the healthcare system to find providers that believe that this is a legitimate diagnosis. This is early days. Think about what fibromyalgia was like 40 to 50 years ago when it was first posed as a differential diagnosis. It was thought to be a made-up disorder and not a real condition. And there is at least now some degree of acceptance and understanding that this is a real syndrome and that patients suffer with symptoms. We are now in the same position with MCAS, and we need to be able to support our patients with testing when testing options exist. Certainly more research needs to be done. And when I say patient education, really we actually also need education at multiple levels. It needs to be present in medical training. And only once we do are we going to get to a point where people have some degree of an appreciation. However, as with many conditions that are new, often the driving force are the patients. So we've seen that with Ehlers-Danlos. We've seen that with multiple inflammatory arthritis like lupus. And I think we can get there when we've seen what good work has been done by the Good Hope Ehlers-Danlos Clinic in Toronto. I think we need something similar for MCAS patients. So I'm going to get off my soapbox with that, but that is where we need to go as a community. Finally, I'm going to introduce to you the person who's going to be presenting after myself. Her name is Becky. And Becky is an absolute ray of sunshine. She came to me just shy of a year ago, and I've been working with her since, and even despite her significant challenges, she's always had a very positive attitude and has been a pleasure to work with. I'm going to only outline some of the medical features of her story, and then I'm going to let her tell you her story, which is rather inspiring. So at the time of her symptom onset in early 2020, she was 40 years old, and she started experiencing significant leg swelling and pain over the course of about 10 days. That was very significant and associated with what's called a levator reticularis rash, chest pain on exertion, and impaired exercise tolerance. Previous to that, about a year prior, she had an episode of bilateral leg cellulitis and otherwise was actually pretty healthy. She'd had some issues with gastritis and had a scope 10 years prior to that, but otherwise was a fully functioning personal support worker, working probably too many hours in a week like many of us, and also extremely active hiking and camping and getting out into the woods. Her past medical history is otherwise significant for hypothyroidism, polycystic ovarian syndrome, and cholecystectomy. And it should be noted she has a history of anaphylactic response to NSAIDs, aspirin, and nuts. So during the course of her 2-week hospitalization, which I was not involved with, but at that time she had an extensive workup. They ruled out autoimmune causes, B vitamin deficiency. They looked for, is there a possibility of multiple sclerosis? They ruled out Lyme disease. They ruled out cardiac factors. And basically at the end of that, they did not have a diagnosis and discharged her with leg weakness and pain not yet diagnosed. And to their credit, I think they could have easily labeled her with functional neurological disorder, but they didn't. She was subsequently followed up by a neurologist who was not clear what her symptoms could be, but did try to treat her with IVIG for 6 months, which was helpful only in reducing some of the swelling and the rash, but the weakness and pain symptoms remained. She also had psychological evaluation to determine if there were any contributors that way that could explain her symptoms, and was told there were no psychological causes for her symptoms. So fast forward to now a year ago when she first met me. She tells me all this, and in light of what we just discussed, I think a lot of you might think, oh, well, yes, it does seem like it's possible she has symptoms consistent with MCAS. So I did the questionnaire with her and she had a positive score. And as such, I moved on to suggesting she acquire the blood testing with tryptase and a chromogranin A. She did have a positive chromogranin A, but it's only one blood test. So from an objective point of view, I don't have enough criteria positive to support her with objective findings, and there are no biopsies that are available for me to request CD117 staining. And my policy generally is I don't send people for endoscopy biopsies just for the purpose of this diagnosis, but rather if they do have symptoms of the gastrointestinal system, I ask the gastroenterologist if they are planning on scoping the patient to consider adding a CD117 stain to any samples they collect. And that's not the case for her. So since that time we've worked together, we did find that she had positive responses to regular use of famotidine for her gastrointestinal symptoms. She was already on cetirizine, so she's maintained that. And we started her on ketotifen and slowly have increased that over the last half year. The patient has made some pretty substantial functional improvements and has had some degree of improvement of her pain. Now we're continuing to work together. Recently, we've started some low-dose naltrexone to further support her with pain symptoms, so we have yet to evaluate that, but that is sort of the medical snapshot of the patient, and she is going to be uplifting you with her story in short order here. So that completes my presentation. I thank the ILC for inviting me to give this talk, and I thank you all for your attention and listening. I hope that this has been helpful and look forward to any questions that come up in the Q&A section of our time today. Thank you.